I always forget how to take it off. So I'm like pressing a bunch of buttons. Hello, everyone. Welcome on this beautiful Ask the Experts Wednesday. I always love seeing all of you. I know people are just getting in. Oh, yeah. Amy just reminded us that it's April Fool's Day. Oh, great. Okay.
Be careful with what you say today.
I know. I'm not going to say anything for this, but you know how like people just like to prank you, and I'm so gullible. So I'm like, I'm going to be spending all day believing stuff that's not accurate. So I'm like, shoot.
I gotta think of something creative for later for you. Then.
I know you got to text me something later, and I'll probably fall for it. So, welcome everyone to this beautiful Ask the Experts Wednesday. We are here every Wednesday at 12 Eastern. It's 9 a.m. here on the West Coast. And Ask the Experts is a live stream brought to you by the International OCD Foundation. And what the Ask the Experts live stream really is an ability for you to hear from different experts. These are people that are trained in treating OCD and related disorders, and they're here just to share their knowledge, answer questions, make comments, give you information, talk about their own kind of personal clinical experience. And just really how I think of it is I have OCD, but if I was still struggling, it would be an opportunity just once a week to be able to just kind of hear like what's the latest in the community, what are different events that are happening, where can I get more information, how can I find a therapist, do people get better, things like that. So we're so happy to have you here. Please remember that this is your live stream. This live stream cannot be as successful as it has been and as just rich as it can be if it's just Victoria and I talking. That's fun, and I love that, but it is so much better if we have you joining in. So right now you may be watching us on Facebook. It could be on YouTube, LinkedIn, Twitch, X, or iocdf.com/live streams. Wherever you're watching us, there is a chat box on your social media. You can ask a question, comment to other people, and just be a community. So please join us, like the live, share the live, heart the live, whatever social media you're on, and we're gonna have a great hour hanging out with you. My name's Chris Trondsen. I host the Ask the Experts live stream. I am a board member of the IOCDF as well as vice president of OCD Southern California, and I advocate for the IOCDF as well as on their BDD, which is body dysmorphic disorder and OCD related disorders special interest group. I also have OCD, and I went through my battle and my struggles and did some great things in my treatment and made mistakes, and that's okay. And just gonna be here hosting. I'm here every week. Normally the first Wednesday of every month we have Liz McInvale who joins us, but she is doing a grand rounds, which is she's talking to I believe at Baylor College. So she's doing a big talk there. So I've done those at USC. They're amazing. It gives a lot of the students just an understanding of what OCD is. And that's so important because as clinicians go through their education, if they're hearing about OCD, they're going to be more likely to diagnose. They're going to be more likely to be able to give that person resources. And we can slowly close that gap of how long it takes for people to get treatment after first signs and symptoms. So we love you, Liz. And Liz has a great treatment center, the OCD Institute in Houston, Texas, which is one of the top residentials in the country. She has great staff. And so anytime she can't make it, she asks her staff. And that's who we have today. So Victoria, welcome. How you doing?
Hello. I'm doing good. How are you doing? Happy April Fool's
Day. I am good. Happy April Fool's Day. No, I'm doing good. I am doing well. Why don't you introduce yourself?
Yeah, so my name is Victoria. I'm an advanced social work fellow at the OCD Institute of Texas and a program clinician. I have lived experience myself. I co-run the IOCDF Young Adult Special Interest Group, as well as just do a lot of advocacy work in the OCD community. But I'm just super excited to be here. I love doing the work at OCDI Texas. I love working with our patients in our residential program. I love working with their families and outpatients as well.
Yes, and I'm so excited to have you. And, we kind of talked yesterday, and I sent over, the one thing. Oh, Ethan's saying hi.
Hey, Ethan.
Hi, Ethan. Okay, so I'm so excited for our April family and loved one support group, which you've been on twice. I put together a panel. It's a psychiatrist. It's my mom. She's going to not play the parent of somebody with OCD. I'm going to host it, but Ethan is going to be our guest with lived experience. I'm so excited because we had, do you know Brooke Miller? She's she was
phenomenal. I watched
it. Yeah. I think what was so good is she was so good. She's a nurse practitioner. She was able to answer questions, obviously in that space, but she answered questions as a parent and as somebody with OCD. And I was like, God, it's just a good reminder at how much education. I always tell my support groups that I can give you guys clinical information, I can give you lived experience, but hearing from people going through it is always incredible. So shout out to Ethan. I'm excited he said yes. Kind of bullied him into saying yes. Not bullied him. I just kept asking him, like, come on, I want you to do it.
That's how it happens, though, you know?
But welcome, everybody. So we're going to jump right in. But before we jump in, the title of today's live stream is like, what does recovery look like? Victoria and I are going to have a little bit of a talk in the beginning. You guys can jump in. I'm going to throw comments and stuff up. Then we'll definitely get to your questions. But before we jump into that, we just have some people saying hi. So I am doing well. I was just telling Victoria before the live stream, I'm doing good. I really have no complaints in life right now. I don't know. I'm doing good. I'm in a good place. Like we said earlier, it's April Fool's Day, and I am so what do you call it? I'm so gullible, so I gotta make sure to not fall for all this different stuff. We have Minnesota, right? I'm so bad.
I second guessed myself too.
Montana? Is it Minnesota? Lisa, I am so sorry. I have never been good, except CA, because I live in California. But yeah, my biggest blunder was somebody was like, "Oh, I'm from NY," and I was like, "Oh, New Jersey." We have Georgia. We have Amy, who said, "Thank you for being a therapist." We have David saying hi. Yes, absolutely. Ash, happy Autism Acceptance Month. A lot of people have co-occurring OCD and autism. So I always tell clinicians that it's so important to understand how to work with our autistic siblings, because it definitely you can do harm if you start treating autism like OCD. My little nephew, shout out to him as both, and you can definitely tell the difference. Yes. We had a conversation about my intro question, Victoria, was like, what is a conspiracy theory that you actually believe, in my support group last night? But we all talked about it. We're like, OCD feels like a big conspiracy theory. It's always just like a trickster and things like that. Hey, Spence, it's good to see you. As always, we have Cape Town in the house. It's so good to see so many people. Yes, my mom, she will be, she will be there. Yeah, my mom is seeing my nephews today, which reminds me, I have something for my sister I need to make sure to bring. But my mom watches these live streams, so especially if she likes the guests, so she'll watch it for you. We see NY, so we do have New York in the house. Yes, most people have OCD and co-occurring disorders. Before we jump in, I like this question by Ash. For April Fool's Day, what's your favorite humorous response prevention message? I'll tell you mine, because I already know mine, so that way it gives you some time to think.
Thanks.
It doesn't sound funny now, but I think humor was so helpful in my recovery. And one of the hardest moments is I was at a CVS buying groceries, and one of the things I used to do is go into the bathroom and like wipe down my money with soap and water, because when I bought the clean items and had to pay, because I didn't have enough money to have a bank account or anything at the time. I was super disabled. I'm just not able to work or anything. But I would go in the bathroom and wipe it. And I had the biggest, at the CVS, I had the biggest just breakdown in the bathroom. Like nothing was working. I was freaking out. I was hyperventilating. Well, the thing is, the CVS was across the street from Laguna Beach. And so a lot of beach people would come in to use the bathroom. So I'm in there for like a half an hour. I have the fan on. I like hear knocking, but I'm just assuming people are knocking and leaving. I'm like crying. I open up and there's a line. And of course, the first people in this line are 3 teenagers. And they're literally just like, dude, you must have taken the biggest dump. We've been sitting here for like a half an hour. And I remember it was like one of those things where I like cried. I was a mess. I remember going to talk to my mom later, and I was like, all these kids are like surfing, and I'm keeping Tide's CEO in business. But I just remember starting to think, it was like I was taking a dump, but I was taking a dump on my life. I was just wasting 30 minutes cleaning money. Then it got on my sleeve, so to clean my sleeve or whatever. So I remember telling myself sometimes, like, you're just taking a dump on your life, Chris. And that was enough sometimes to get OCD to shut up. So I don't know if you have one.
I love it. I think my favorite one was like, every time I was in a spiral, I would just say to myself, like, come on, man. Like, what are you doing? Like, let's keep going. Don't kind of frown on this.
Yeah, no, seriously. I think sometimes humor can work. I know it did for me. It was just like a good way to kind of just recalibrate. It didn't work for me in the beginning when I was at my worst, of course. But yeah, it does. It really takes a dump on your life. Sarah, thank you so much for your kind words. So, all right. So, Victoria and I are going to talk for a little
I
bit.
was like, do not call me Vicky over
No,
here.
I don't know why I said who calls you Vicky? Somebody.
Nobody. My cousins used to call me Vicky.
Okay. Yeah, I don't. I have a aunt Vicky, who I love. She's amazing. So Vicky's a good name, but I didn't mean to call you that at all. Yeah, I like that. Bring it on. Yeah, no, I know it is hard. I think, humor wasn't, like I said, humor did not work in the beginning. I was just too miserable. I was too in it. I was too low insight. But I think as I got better, I was able to do things, maybe not humor, but to me, it was just sometimes just literally being like, dude, shut up. Like, I'm not going to go back to the store and count or check or whatever it was that OCD really wanted me to do. But you know what, Victoria, I named, we talked about naming this what recovery really looks like. And you could start either with your personal journey with OCD, or you could start with clients. What does it look like? Because I get asked that a lot. People going through treatment is like, what exactly is this treatment going to do for me? What does recovery look like? What is putting all this effort and work into going to do for me? So when you think of OCD recovery, what does that look like for you?
Yeah, I think one of the big things that I'll start with, and I think of Sarah's comment about these live streams have been so helpful in my recovery journey, because I think that was one of the things that was so helpful in my recovery journey. And I remember when I was going through treatment, I didn't really understand what recovery looked like, right? Like, you heard so many different things, and you still do hear so many different things about what recovery could look like. Maybe you have to live with it forever. Maybe you can get freedom, right? What does freedom actually look like? All of the above. So when I think about recovery personally, I think about the idea of being able to make decisions based on what I want to do versus what OCD is telling me to do. And I translate that into clinical practice too, right? I think one of the biggest questions that I ask my patients is, if OCD wasn't in the picture, what would you want to be doing right now? And that really helps them to see what recovery could possibly look like versus staying stuck in that OCD cycle. So I'll talk a little bit about freedom from OCD and what that looks like, because it wouldn't be a live stream without talking about freedom, especially when I'm covering for Liz. Yeah. But really in the sense of not allowing OCD to make decisions for you, being able to experience the random thoughts that we all have on an everyday basis and not let them trigger us, right? Not let them interfere with our life, be able to choose things that are aligned with our values.
Yeah.
Kind of answer to that.
Yeah, no, I always tell people, I'm like, the biggest change that you will see if you are doing treatment, and I always tell people too, recovery isn't like you finish treatment and then you're in recovery, right? Like, recovery is a process, but one of the big things I tell people is that recovery really is getting to a point where kind of, you said it, right? Like, where every day your decisions are not influenced by OCD. Now, that doesn't mean necessarily OCD won't show up to the party and kind of try to ruin it, but let's say you get invited to go to Disneyland, right? Your brain's going to come up with 15 reasons why not to go. If you have harm OCD, maybe you're afraid that you're going to push somebody off of a ride, or you're going to harm a child when you're there. If you have scrupulosity OCD, right? Maybe you feel like that somebody's going to have a t-shirt, or somebody's going to say a word that triggers scrupulosity, like, oh, it's hot as hell out here, or something like that. If you have contamination OCD, right, you're touching a lot of public surfaces. If you have checking, you may put your stuff in a locker and keep going back and forth. Hit and run OCD, you might think you're going to hit somebody on the way, or just right, you're trying to get on and off a ride and they're like, get off, and you're like, it doesn't feel right. So your brain is going to come up with all these reasons why you shouldn't go. I think of recovery as saying, I hear that, but I'm choosing to go despite those warnings. I'm going to use my tools. I have a set of tools that are really helpful, and I'm going to use that. And I'm going to recognize that my brain is learning during that process. I am learning and gaining new information on how to live without the OCD being an influence. And so let's say you have contamination, right? It's like getting there and saying, okay, what are some rules or some sort of goals I want to hit while I'm there? What's maybe either with something you've witnessed with clients, or maybe in your own journey, that it's like you saw that happen, where it was like, maybe something that you normally did, or you see a client normally doing, was so hard, and through treatment they got to a point to be able to do that thing despite having OCD and not letting OCD influence it in any way.
Yeah, and I think, wow, I can't even choose one to share. I can just see like so many of them. I'll share a little bit from my personal experience. One of my biggest fears was getting gas in my car and going to the gas station. And I vividly remember the one day I saw that shift where I actually started to enjoy getting gas. And not many people say they enjoy going to get gas in their car.
Not with these prices, let me tell you.
No, I'm good now. I'll stay back. But it was one of those things where I pulled up to the gas station and I got out of the car without even thinking twice about it. And I didn't even realize that I didn't think twice about it until I got back to home later, where I was like, wait, I just filled my car with gas. Like, and I didn't think twice about it. I put a little bit of Purell and moved forward and went on with my life. And I think it was one of those things where I started to realize that I didn't need to let OCD have control over me. And that's something that I love seeing when I'm especially working with our residential patients, is because we see them all day long, right? 24/7. And we see their kind of, you see this like light, right? This, whether it's your eyes or whether it's like the brightness of your face, to say, wow, I was able to do that without wanting to do a compulsion or without just experiencing those high levels of anxiety. So I think one of the things that just helps overall is understanding too that this is not like an easy process, right? So when we think about recovery and we think about kind of seeing that switch from OCD is taking over my life to, wow, now I'm actually able to enjoy my life and do the things that I value, that's not going to happen overnight, right? That's not going to happen in this like quick instant where you just see it, right? It's going to happen over time as you're doing those exposures, as like you said, Chris, like you're retraining your brain, right? And you're learning something new, because right now your brain's kind of so stuck in OCD land.
Yeah. For me, I remember traveling, like the first time really enjoying traveling, because traveling came with so many things. That health-related OCD, I was really afraid to go through x-ray machines. I was afraid all my items that would go through the x-ray machines would have some kind of like radiation now stuck on it. And when I would use it, it would make me sick. Didn't like the contamination, obviously, of sitting in public places. A lot of fear that I was going to die on the plane, like something was going to happen. I didn't like just like the closed-in feeling. Staying in a hotel that wasn't mine. I mean, just the list goes on, right? But I think what was so cool is, like you said, you'll have those moments. Like I always tell clients, like the first couple times may be sacrificial, meaning like the first couple times of traveling wasn't great. There's a lot to overcome. But if you can think of treatment as inhibitory learning, meaning your brain is reteaching itself and reconnecting, kind of making new associations. So at one point for me, it was like, traveling was associated with like fear, and it was negative and I didn't want to go, but I kind of recreated an association of like getaway, relaxation, like space, time, right, to myself. But I remember that just being on a plane once and be like, this is cool. Like, I think it was probably going to like an IOCF conference, just like, I'm going somewhere, I get to go on this plane. I mean, now the airports are crazy, but it was just kind of nice. It was like, oh, I'm like, going on this trip, and it's cool to be able to travel, even though this was hard. Or the dentist. I mean, it's not as fun, but I just remember like going to the dentist. I still to this day enjoy going to the dentist. And I was like wondering why, because people always talk how they hate it. Yeah. I think what it was is I didn't go to the dentist for so many years because of OCD. I was so fortunate, knock on wood, that because I was overbrushing, I still cut my teeth okay, damaged them by overbrushing, unfortunately. But at least it was like, oh my God, like I'm doing normal stuff. And I think that's happened sometimes. When you kind of do normal stuff. What does, obviously there's recovery and we're talking about kind of that. When do you kind of see in clients or seeing yourself like beyond that, right? More so to getting a point where suddenly you're noticing like, wow, I'm having like so little thoughts, or man, I went the whole last couple days and didn't even feel like I had OCD. Like, what does that kind of look and feel like?
Yeah, so we actually talk a lot about that, especially when we're prepping patients for discharge from our res program, in the sense of like, we've helped you get to this point where we're able to get back into your life, right? You're able to go back to work, go back to school, enjoy those hobbies, but that doesn't necessarily mean that OCD isn't going to show up, right? So that's really kind of this last like 30-ish% of treatment where we're really seeing them engage in their life. Right. So when we talk about when we start noticing days, maybe weeks, it could even be around, we're not even recognizing OCD. We're seeing them engaging in their hobbies. We're seeing them engaging in values-based activities, doing things that they want to be doing, right? Not things that were trapped by OCD, right? Like just like you were traveling and you're going to the dentist, right? I don't think I can ever enjoy going to the dentist, but that's not your story. But like you are doing things despite feeling anxious, right? And you're not even recognizing it. So we often tell people a lot of times, and I know that I've went through it too, is I thought that I would like recognize when OCD wasn't playing a role in my life anymore. I thought I would be able to like in that moment, in that spot, say to myself, like, look, I'm making my own decision. I'm not letting OCD make the decision for me. And that's something that I think a lot of times people just like misunderstand is they think like there's that one moment, there's that one aha, whereas we often see it over time. We often see like we're actually living life and then we're able to look back and say, wow, look, OCD didn't affect me like that.
Yeah. Yeah. I mean, I think also as you re-engage in life, I don't think people always think that that is part of recovery, but for a lot of people, their life has been uprooted because of OCD. So maybe they've dropped out of school or they're not working, or I've had it where some people move out, like they're married with kids, but they have to move out of the house because their OCD is so bad affecting the kids getting to school, right? So I think part of treatment is getting back into life. And what's cool and what I found in my own recovery and what I see with clients is like as people are navigating into real life, new triggers will show up because somebody will say something at work that triggers you, or your coworkers want to go out to happy hour and you're around alcohol and you're like, what if I just chug alcohol and do something crazy and and get fired? So all these different worries. But as people use the tools and recognize, I always tell clients like the tools, ERP, and whether that's with ACT or CBT, DBT, etc. It's like an equation, right? Once you've learned an equation in math, new numbers may present slight challenges, but it's not like you have to relearn the equation. And so once you get to a point of applying that over and over, you start to get into a rhythm. And I know for me, it's like working at LA Fitness was one of my first jobs back from treatment. It's like in the beginning when I was touching people's keys and scanning them, using the public keyboard to log people in, taking the dirty towels from people working out and throwing them in the washer. I mean, all of that was a process. But you just do it consistently enough because consistency is such a big part of recovery. And suddenly it's like you have those days where it's like, oh my God, I was at work and not once did I wash my hands nor feel bothered, or I had a lot of harm OCD because I was carrying heavy weights. People would be laying down bench pressing and my brain would say, what if you just dropped the weight on the face? And then went into this acting role of like, oh no, it was by accident and got away with it. Like that was a big part of it too. It's like, oh, you're so evil, you'll try to get away with it. And it was like, so what did I do? I re-racked weights. I would offer, I'd be like, I'll do it. And then you just get to a point where one day I'm like just walking around the gym, re-racking stuff, people saying hi, and you just forget. So for you personally, like what does that feel like as somebody where you're just like, man, it's not even like I'm fighting it anymore. Like this just doesn't come up for me anymore.
Feels great. I think there's so many times where I look back and I kind of question what I went through, right? Because I'm like, that didn't feel real. But no, like currently, I think it's one of those things where it just feels so empowering, right? It feels empowering to just be able to get up every day and come to work and not have to worry about, oh, my gas tank is low, or, oh, someone tampered with my water while I left it in the office, right? Like you're just able to enjoy life. You're able to make new memories. You're able to have fun. You're able to create new memories, right? Like in the sense of try things that you never even thought you would try before. Like I never would have imagined that I would like hop on planes all the time and travel and go to different places, and that I didn't even recognize was OCD when I was going through it. But now I travel often, right? Like I am originally from New York and I go home a lot and I love to just get on that plane and go. I love going to the ISDF conferences. I'll be at ADA next week, right? Like just being able to get up and do the things that I want to do just feels amazing. Right. And I think this is something that I'm curious, Chris, to hear your perspective on, is because we also talk about this idea of ERP as a lifestyle. And does ERP as a lifestyle necessarily mean that we have to be doing exposures every single day for the rest of our life? I'm curious to hear from your perspective, what does ERP as a lifestyle mean to you?
Yeah, I think a lot of times I get that question a lot, either about my own personal journey. Like, do you have like a list and you're doing exposures every day? Or people will ask, like, am I going to be doing exposures every day? And I say, no. There's how I think about ERP as a lifestyle is, in my head, I think of two phases. Like in the beginning, when you do need to be a lot more kind of like deliberate and intentional with your treatment, the lifestyle to me is like, what are we doing here? I think people get so boggled down in the logistics, but in a bigger kind of, if you zoom out, the idea behind ERP is saying, hey, there are a set of events and people and objects and all these different things that at one point I enjoyed. I lived my life around these things. This was a big part of my life. And my brain has told me suddenly that all these things are bad for made up kind of reasons, right? And so the treatment is getting re-engaged. And that's the E part, right? Like re-engaging with those things that sure may create some discomfort, but they're associated with things that are either necessary in life, like traveling, or something you enjoy, like holding your niece, right? The idea behind response prevention is you have to have a coordinated response in your brain. If you're holding your niece and the whole time you're like, please God, don't drop her, please God, don't hurt her, you're sending mixed signals. Now, once somebody has gotten to a point where they're like me, do I still feel like I have ERP as a lifestyle? Sure. Does that mean I have a list of exposures I'm doing and OCD's popping up and that's how I do it? Of course not. But the idea for me is like, anytime something becomes difficult or hard, I'm going to face it. I think for me, I'm very honest about it. Like, normally OCD doesn't pop up unless it's something brand new or something I haven't done before, right? And so I'm dating right now, and there's some things that have happened in dating that haven't happened in a long time because I haven't been this serious with someone. And ERP as a lifestyle means to me, like, I don't even joke around of the idea that I'm not going to go to that place. I'm not going to, for me, I have a lot of like disgust-based OCD stuff, and I have eczema, unfortunately, and my scalp is very sensitive. I have to use a certain product for it, and it's sticky, and I hate it. It feels like it's getting everywhere, and it's sticky or whatever. But I have made a commitment that every time I go on a date, I want to look fly, I want to look good, I want to stay in this relationship, I'm going to do my damn hair, right? And then the response prevention. I'm not going to sit there and like have this space where I have to do it and then decontaminate, right? So it's a lifestyle. It's just like I'm facing things. I'm never saying no to life simply because of OCD. So I know at first it can seem exhausting to really have this sort of like systematic way of doing things, but ERP as a lifestyle is just the idea of like, go after it. And here's the thing, John Grayson says this a lot. I know Liz does as well. People that do ERP, I see it in other places in my life. I'm the yes person. Let's try it. Let's do it. Why not? I'll figure it out, right? And I'm not going to worry about things that aren't currently occurring. So that's how I see it. I don't know if you guys have a little bit different of a way of seeing it, or if that you relate, or
no, completely 100% agree. And I think Ash's comment at 11:26, well, Central Time, really summed it up, right? So life presents you with non-optional exposures every day, and we can choose, right? We can choose to lean in OCD's direction or into the ERP direction. And I think I see ERP as a lifestyle is whenever I get presented with something where I'm kind of I'm a little nervous about this, right? I'm gonna choose to lean into ERP. I'm going to choose to lean into what I care about versus what OCD wants me to care about.
Yeah. No, I think it's so important, right? It's just so important to get to a point where it's like, you just don't, to me, it's like, I don't allow OCD to have relevance anymore. And I think that that's what it means, is to just like really, really buckle in and get to that point where you just don't allow yourself in any kind of way to even entertain it. It's just not important anymore. And I think that's as a lifestyle. I think once I left treatment and I was just living life, I really saw ERP as a lifestyle for me at the gym. That was a big example. Or martial arts, right? My harm OCD, when I was a kid, I remember doing martial arts and I was in between ages. So they had me go with the younger. I mean, they weren't like 10 years younger. They were like maybe 2 years, but I was bigger at that point. And I remember sparring and like hurting two of the kids, not like permanently, but just like hurting them, and they were crying. So they moved me up. But I remember going back into martial arts and having a lot of harm. What if I hurt someone? And then I remember at a tournament, they had me spar with a kid that, well, I wasn't a kid, I was probably like 22, but they had me spar with somebody that had like some kind of heart thing. And I was like, what are you guys doing? And it ended up, he got hurt. I'm just like, but it was one of those things where it's like, I did it. I went every session, every, lesson. I went to every kind of group lesson. I just never said no. I was like, I'm going to figure it out. And that's why I tell clients, like, jump in and figure it out when you're there.
Yeah. And have fun with it.
Yeah, exactly. You can have fun. I wanted to throw this up there. We got a question from David. So there are parents of a 25-year-old with OCD. They struggle constructing a team, so like a therapist, a psychiatrist support group to support, which is, challenging. Is there such thing as a navigator who specializes in OCD can help us put together a team or guide a treatment plan? I'm going to go first, but I'm going to let you answer at a more elevated level because I know it's very different for residential. What I'll
Mhm.
say, David, is what I would personally start with is I would personally start with a therapist. If I'm going to let Victoria jump in because she works at a higher level of care, like a residential, and the answer is going to be different. And I would say if your son is 25, let's say he's really struggling, he's unable to do the basics like brush his teeth, sleep normal hours, work, school, etc. I think there is a fear of putting people in a higher level of care like it's a bad thing. As someone that runs an intensive outpatient program, it is a blessing for people that need that level. And there's people that do not qualify for an IOP. They're really, really, really severe, and a residential will be helpful. But I'll just answer it from, let's say they just need weekly. Where I would start, there isn't really a navigator. I do know that I don't know a lot about it, but I do know that there are some people that can help with residentials and finding residentials. But what I usually say is like find an OCD therapist, right? Someone who really specializes, who's really connected in the community. As vice president of OCD Southern California, I know so many of the psychiatrists, therapists, support groups in the area, right? That therapist may run a support group or they might know a fellow clinician who runs a support group. And then I have a list of like 30 psychiatrists that over working in this field for 16 years, I've really built like clients have built relationships and say they work. So a good therapist can help you navigate the team. That's sort of my role, right? And I also have a lot of really good referrals if somebody has co-occurring trauma or they have co-occurring like relational problems or they have ADHD too. So a good therapist could help. But I know at the residential, you guys do that as well, probably much more streamlined.
Yeah, so and I think, like Chris said, is start with just finding a really good OCD provider, right? And you can do that through IOCDF and just kind of have that foundational start. I do know that there are educational consultants that do help with finding programs, and we work with a lot with educational consultants. But in the terms of kind of the residential level, here at OCDI, we have your primary behavioral therapist. You also have a family therapist. You have a psychiatrist, and we also have a case manager that's going to help you kind of work through discharge plans and life after treatment and all of the above. So I think one of the big things is if we are able to get you in the door, right, and just be able to help walk you through the process. And most residential programs have an admission process. So you're doing a video assessment with a clinician, help like navigating through what's the right level of care, are you a good fit for us, and be able to go through that. So I don't think that there is necessarily such a thing as a navigator who specializes in OCD that can kind of guide that treatment plan. But if you are in need of a higher level of care, we're more than happy to really work as a team to help you set that up. And like Chris said, is we have our whole list of providers, we have psychiatrists, we have support groups, all of the above, that it's going to be able to help you get the right support.
Yeah, the only other thing I'd shout out is maybe one of the affiliates. So the International OCD Foundation is based in Boston, but they have affiliates throughout the country as well as overseas. And a lot of times people reach out to us, and we can't, as an affiliate, obviously that'd be favoritism, right? Tell you like, hey, these are the top people, but we can lead you to different resources and stuff in your area. So if you go to the IOCF website and you look up affiliates, you'll see an affiliate hopefully in your area. I'm curious about this for you, as well as kind of maybe how you talk with clients about this. But I think one of the things that we talk about with OCD is kind of like naming it, separating it from ourselves, talking about it almost as if it's a separate entity. I think it helps both with the person, but also the family. Because if the family's saying like, Victoria, why are you doing this? Victoria, why are you doing this? Instead of, hey, Victoria, I see that the OCD is really, really capturing you right now and it's making you late. Is there a way you can disengage? Because we got to leave, right? Talking about it as this other entity. So Spence was saying like, seeing it as like an overprotective parent, but also saying personifying it as like a terrorist or evil malware is just as effective. How do you see OCD? Do you personify it different now where you're at based on when it started? What seems to work for clients? What's something people can do to personify it and separate it from themselves?
Yeah, no, absolutely. I love this because I'm one of the big I don't know what the right word is here, but a big fan of naming your OCD, right? And really separating it from yourself, because when you how do I want to say this? When you place your entire identity within OCD, you get trapped, right? And it's very hard to find a way out of that. So one of the best things that I could have done in my treatment is name the OCD, because exactly like Chris said before, is especially when I was dealing with my family members provided a lot of accommodations, and they really had to learn to remove those accommodations. And what was one thing that they kept saying to me was, hey, we are removing accommodations because we don't like your OCD, right? My OCD's name was PETA. So like, we don't like PETA, right? We love Victoria and we care about Victoria and we want the best for Victoria, right? So it's really helpful for me too to hear that they weren't punishing me, right? They were punishing OCD. They were saying, we don't want OCD in your life anymore. We want Victoria back. We want Victoria to be happy and joyous, and because we know she's under there. Right. So I think that was one of the things that helped me the most in my treatment. And how I really talk to patients about it is exactly like that, right? Is when you identify with OCD, it is very hard to see the other side. And for a lot of patients, it's very hard to name their OCD. And I don't think I was able, I really don't remember, but I don't think I was able to name it right away. I think it took me a couple months, right? Because I truly felt that OCD was a part of my identity. So I kind of just frame it in the way of, hey, like, we don't want you to feel like this is you, right? We want you to feel like this is a separate person that you're able to disconnect from. So being able to, when we're doing exposures, when we're kind of triggered, being able to say, hey, that sounds like OCD's talking right there, right? That doesn't sound like Victoria, and be able to bring Victoria back.
Yeah, what I like to talk to clients about is OCD is not a personality disorder, right? Personality disorders are a little bit trickier because in the sense that it is kind of fused with the person, but OCD is not a personality disorder. It's a disorder, right, of obsessions, of compulsions that bring on strong emotions like fear, anxiety, shame, guilt. But it isn't you. It isn't something that is in you. It is something that's ego dystonic that you feel attacked by, right? So we have to talk about it as a separate entity. For some clients that don't like to name it, I'm like, at least let's change language, right? It's not your OCD. It's your experience with OCD. Don't own it, right? Nobody goes around and is like, oh, sorry, I couldn't make it. My cancer was acting up, right? So you can even say the OCD if it helps, but talking about it as if it's a disorder and it's not you. I always get nervous when people are talking about like their OCD symptoms as if it's just them. And a lot of clients will say, like, as they get better, they're like, oh, I'm not, I always thought I was like rude or introverted or X, Y, and Z. It wasn't ever me. It was the disorder. Exactly. Right. But naming it, or at least like in my own treatment, I thought of it as like the captain of the enemy, not enemy team, but the captain of the competing team. And it's like, when I go home this week before I see my therapist next week, either I'm going to win or the OCD is going to win. So how do I tackle it? So I think seeing it as a separate thing could absolutely be helpful. I forgot one thing. Ash, Chrissy Hodges, I'm going to put her name in the chat. So for anybody, but Chrissy Hodges actually does do that. I totally forgot. Shout out to Chrissy. So as an OCD peer support specialist, she's actually in school right now to get her master's. But that's one of the things that she does provide. She doesn't do therapy yet. That's what she's going to school for. But she actually does offer, so I'm putting that in her info in the chat, but she actually does offer those kind of services where she can find like the therapists and psychiatrists in your area. So please check it out. This one's tough, right? OCD hates change. OCD hates things being different. So Mohammed says, having huge trouble with relocating to a new country with OCD. Uncertainty is too much. How do I overcome fears related to relocation alone? I'll jump in a little bit, and then I definitely want to hear your experience. I would say that with OCD, so I was watching something by a neurologist, and he was saying, when we want to go do something, our brain comes up with a couple potential challenges or obstacles in that path. But our brain isn't saying that so that we won't do it. Our brain is just saying, hey, I'm going to throw some things out there. Some might be relevant, some might not. Decide what you're going to do with it, right? So if you're going to go out with your friends that night, your brain might say like, oh, but you work. How are you going to race home and get ready in time? Or, ooh, you want to drink a little bit, so you have to make sure to get an Uber, right? Your brain's not saying that, so you're like, you're right. Sorry, not going to go out. It's more so like, you're right. I got to set up the Uber. I got to make sure that I don't dilly-dally after I get off of work. I go straight home and change, etc. But I think a lot of people hear those things and are like, you're right, it's too hard. I'm not going to do it. Now with OCD, we're going to get much more extreme potential, obstacles. You're going to fly and you're going to lose all your luggage, or you're going to get sick and there won't be a hospital in the country you're in, or you're going to go to church in a bad thought and go to hell. So we have all these thoughts. So I think with you, Muhammad, your brain is coming up because there's so uncertainty and your brain can kind of make up whatever it wants because you're not there yet. It's coming up with a list of really, really scary things that are going to happen in the move, along with just general uncertainty. And your job is to say, well, I'll figure it out.
Mhm.
These challenges are going to arise just like they would if I moved 2 towns over. I'm going to have to come up with, there's going to be new culture, there's going to be new rules, new laws, a new way of doing things. But what if instead of being scared, I was curious? What if I adapted? What if I learned? What if I actually enjoy it? What if the challenges that come up, I overcome them? And the ones that I don't, I just trust that there's a service for that, or I can lean on someone, etc. So I think once you start to see an opportunity to trust yourself, that you'll be able to rise above and really handle it, this can actually be exciting because there's a reason you're moving and it might be something that you actually enjoy. And look, if you hate it, you can always move back. It's not easy. I'm definitely simplifying that, but ultimately that could potentially be part of it too.
Absolutely. I love that. And I think one of the big things too here is this idea of coming back to what's the choice that we want to make, in the sense of, are we really going to lean in and explore here, right? And think about all of the progress that we've made in the past with other OCD symptoms, right? And how can we apply those same patterns to this, right? Now, that's not saying it's easy. It's not saying it's going to be a simple ride, right? But it's one of those things where we want to say, okay, where can I start, right? And that start can be so small, right? Maybe it's, well, I'm afraid to walk to the grocery store. Okay, so let's start with just walking to the grocery store, right? We don't have to go out and do all these big things right away. We can start small, and giving yourself that grace and compassion to start small, right? I mean, I think one of the big things that I talk a lot about is I relocated halfway across the country and I was terrified, right? I didn't know what I was going to run into. I didn't know what was going to happen. And one of my goals that I remember setting in treatment was to get my own apartment. And I remember really setting like myself in this mindset of, I'm so excited to get my own apartment. I'm so excited to explore this new life that I am not going to let OCD like pop in and interrupt this. And did OCD creep in? Yeah, absolutely. Right. But again, it was how I responded to it. So really kind of practicing that ERP as a lifestyle, really saying to yourself, can I start small? And can I work my way up into those bigger things?
Yeah. And moving, I would say, is one of the most stressful things when they've looked at things like what causes people a lot of stress, like public speaking. Moving is definitely up there as well. And I know moving was super, super anxiety provoking for me as well. I think it just like you said in the comment, Muhammad, just that uncertainty. But remember, your imagination can make up whatever it wants because you're not there yet. Once you're actually physically there, it's a lot. I always tell people like, the current moment, the here and now, like when you're there and being present, is kind of boring because suddenly it's like, wait, all these things my brain said was going to happen at church or at Disneyland or moving can't really happen. It's not that exciting. So I think it's definitely recognizing that. But good luck. That sounds exciting.
You got this.
Yeah. So Nathan says, my psychologist told me that personality disorders are hard to treat. I think everything's relative. I think what's challenging with personality disorders is typically they come from like a place of a lot of trauma, a lot of like really, really difficult past, a lot of, sometimes PTSD, sometimes attachment. And it's a lot harder for people to recognize because with OCD, those of us that have it, we know it's ego dystonic. Like I knew a lot of this stuff was like made up or extreme. I just felt compelled. A lot of times, personality disorders can feel more ego syntonic. Like the things that you're experiencing feel really, really intense. So one of the personality disorders that a lot of people have co-occurring with OCD is OCD personality disorder, OCPD. Typically in the media, when people are like, I'm so OCD, I love to organize my or my closet, right? But like true OCPD is where somebody really wants to control most things in their life. They have very strict and kind of like rigid rules they live by. That may be how they do things at work. So group projects are very difficult. It might be how they want to run a household or a vacation. It might be the certain values that they hold and expect other people to hold them because they're right. and they try to control their entire life, and they get pleasure doing it. Really, the only discomfort comes when somebody is kind of invading their space and trying to get them to do something different. So if the only time you feel anxiety is when somebody's kind of trying to change who you are as a person, it feels like a personal attack. And really having to recognize, like, hey, the way that you are kind of programmed is actually causing a lot of distress for others. Therefore, you have to make some more flexible adjustments despite it feeling like innate. At OCDI, do you guys treat personality disorders? Do you refer out? Like, what do you see with personality disorders and co-occurring OCD?
Yeah, so if personality disorders are secondary and OCD is primary, we're happy to help out with that. If a personality disorder becomes primary, then we would refer out. And I think one of the big things that when it comes to personality disorders is really just like the importance of finding an OCD specialist, right? Finding a specialist that treats personality disorders.
Yeah, there's definitely specialized treatment for that. Just like, for instance, like radically open dialectical behavior, right? Like DBT. So typically DBT is more about like regulating emotions. Somebody with OCPD, for instance, is really good at that. So they need radically open to be more flexible. People with borderline personality disorder, dialectical behavioral therapy is very good for them because it helps them regulate these emotions. So there isn't these kind of like impulsive actions. So, but definitely if you get, make sure to find a specialist. I know it's difficult. I think just like a general doctor, they can help you with kind of everything. They refer out when it gets to a certain level, same thing. Mohammed asks, are crying spells due to MDD, so major depressive disorder, highly comorbid with OCD? So maybe you can start and just talk about, like, what do you see with a co-occurring OCD and depression? Maybe let's
Yeah, we see it quite often, and I think a lot of it. And well, first you have to parse apart, right? Is it depression due to OCD, or are they two separate things? But I think we see a lot of MDD co-occurring with OCD because OCD does steal your life, right? And it makes you feel like there's not much else out there, right? And makes you feel like you can't engage in the things that you enjoy and value. So one of the big things that we talk about is like engaging in behavioral activation and making a list of values-based activities, mastery-based activities, pleasure-based activities, and being able to engage in those despite however we're feeling, right? A lot of opposite action. But I think one of the big things that gets a little bit more tricky, right, is when they're almost two separate entities, right? So we're treating the MDD and we're treating the OCD because they require a little bit of a different treatment, right? They require a little, like, MDD is more around behavioral activation and cognitive behavioral therapy, more evaluating cognitive distortions, whereas OCD, we're more engaging in exposure and response prevention and really facing those fears.
Yeah. Oh, go on. Sorry.
No, go.
Oh, I was just going to say, Mohammed, like, the DSM currently says about 63% of people with OCD will have a co-occurring depressive disorder at some point in their diagnosis. So I always want to normalize that because I think a lot of times people feel like they're another because they're like, oh, I have OCD and this, but almost, 2/3. But yeah, crying spells are a big part. I mean, depression, people present depression differently. Some people, it's a lot of crying. Some people are numb and shut down. Some people get very angry. Like, we all have different coping. So one of those things that I would suggest is making sure. The nice thing is, medication wise, we'll have Dr. Sanjay Saxena on next week. So if anybody has specific medication questions, he'll be on. He's a psychiatrist based out of San Diego, California. But medication for OCD, like an SSRI, so a selective serotonin reuptake inhibitor, or frontline medications, will help with both the depression and OCD. And then, like Victoria was saying, sometimes people's depression lifts as their OCD gets better because they get back to life. But some people have co-occurring major depressive disorder that does get impacted by OCD, but maybe there's other things going on as well, and so addressing it. So making sure that you're doing it. I mean, one of the biggest things with behavioral activation that I tell people is got to be out each day. I know my clients are so sick of me saying that, but I'm like, think of depression. What does it want? It wants a comfy bed. It wants the sheets over your head. It wants the blinds closed, and you'd ignore everybody. And we don't want to do that.
Absolutely.
This would be a good one for you to ask. Amy says, what do you do when you need a higher level of care, but your insurance does not allow you to go anywhere?
Yeah, it's a tough question, right? It's one of the unfortunate things, especially around like the OCD higher levels of care and residential programs, is there's only 3 of us in the country. 2 of us accept insurance. So McLean and Boston accepts insurance and Rogers accepts insurance. We unfortunately are not in network. We do some single case agreements, which is kind of like I'm not a big insurance girl, but like kind of this area where the insurance company agrees to pay for treatment. But that it's tough, right? So I do think a lot of places offer scholarships as well. We offer a scholarship here for our partial hospitalization program. So if you are in need of a higher level of care and insurance is not covering anything, we would encourage you to apply for our scholarship program. And I'm not positive if McLean or Rogers also has scholarship programs, but it's something that you can look into. But I think it's one of the big gaps in our field that we're looking into.
Yeah, I don't work at a residential. I work at the Gateway Institute in Orange County, but we have an intensive outpatient program, and we've gotten in network with Kaiser, so people with California Kaiser can get their insurance to cover. And the way it is for Kaiser is you go to your psychiatrist, even if you're not on medication, they have you see a psychiatrist who then deems that you need a higher level of care. It's very challenging with insurance. The good thing is we've done some live streams in the past, and there's been talks at conferences about how to really utilize your insurance and make sure that your insurance can help. I think a lot of times when you talk to treatment centers can try to reach out to your insurance and navigate that as well. But I think the hardest thing, what I tell everyone is, despite your politics, make sure your local and state and federal, people that you vote for have some kind of plan to make insurance actually do what it's supposed to do. And for autism, I believe it was 2012 or 2014, but they passed where insurance has to cover care for people who are autistic. My nephew who's autistic, like, it's been incredible. I mean, his insurance has covered all of his different treatments, his OT, his speech. He goes to a special school right now that it's with all other autistic kids. He's thriving. It's normally something like 40 grand a year, and my family doesn't have 40 grand a year money, and the insurance covers it. The city does as well. So I've seen with my own eyes what it looks like when an insurance company is forced to cover all aspects of care, and my nephew has thrived because of it. And it infuriates me that insurance doesn't do that for OCD. So the only thing we can ever do is the IOCDF is continuing to lobby, trying to get in front of different government officials, but really talk to a treatment center. They can talk to your insurance company. I wish I had it. But if you look at if you go to YouTube and you go under live, there's past live streams. I'm trying to think who it was. Hopefully I'll remember by the end of the stream, but we did a live stream about how to utilize your insurance. So let's talk about this. So as part of recovery, Amy says, I think one of the things that, one of the members of my group last night was saying he really struggles. He has a friend who's like really thriving in life, and they grew up together. And he's like, my friend knows his worth, and companies like goes for and asks for the right salary or takes on new jobs, is just so confident. And because of the OC, it's left him feeling like he isn't confident. He doesn't trust himself. He doesn't have value. Can you talk a little bit about, beyond just like the symptoms going down, how does treatment help somebody with OCD start to have a little bit of faith in their abilities, start to talk to themselves in a more positive direction, and just overall thrive better as a human being compared to not?
Yeah, no, absolutely. I think that's one of the most amazing things about exposure and response prevention is it teaches you these skills that you don't just have to use with OCD, you can use in everyday life, right? So you're just really teaching yourself that you can handle really tough things, right? You're teaching yourself that you can respond to things in different ways, and you don't just have to have this one anxiety-provoking response. So when you think about really kind of generalizing treatment, right? We're talking about this idea of being willing to go back into accepting uncertainty, right? And uncertainty is unfortunately a part of everyday life. And those of us with OCD feel like accepting uncertainty is really, really tough, right? But through treatment, you're able to teach yourself that you've been accepting uncertainty in a whole bunch of other areas of your life, and you can do it in these areas as well. And even things that pop up that don't relate to OCD. Right. So I think one of the big things, and I remember kind of thinking about the COVID era and this idea of a lot of times, like, there was a lot of uncertainty in COVID, right? There's a lot of unknowns. There was, I don't really know what's going to happen. When is the shutdown going to end? Like, I don't have confidence, like all of the above, right? And I feel like one of the amazing things about ERP is it taught me to really just go into it with one of those attitudes of, okay, it is what it is, right? And I'm going to get through this just like I got through everything else. And can I trust myself? Can I build confidence in myself? Can I get through this, right? Without letting it impact everything else.
Yeah, 100%. I feel way more confident in my abilities. I think that's the big thing. Before, when OCD would say like, but what if this happens? I'm like, you're right. Now it's like, well, what if this happens? Well, cool. I'll handle it. I can handle stuff. Like, have some confidence. I'm a good friend of the show, Patrick. It's always good to see you. Patrick, hello, hello, hello. Patrick's amazing. Dr. Patrick McGrath. He is over there with OCD, but he's also been an OCD provider and now just a huge part of our community. And it reminds me, I need to reach out about something, Patrick. I need to get him on my family group. I need to get him on a live stream. He's the buddy. He's so awesome. Love you, Patrick. I wanted to get to some pre-submitted questions. So this came from a person who is a support group member, and they are struggling a little bit about like their role, because it sounds like in their support group, I was reading the longer question, trying to make it shorter for us. It seems like in their support group, like sometimes people talk afterwards, and they're just basically asking, like, as a support group, like, what can I do? How does a support group help people? And how is it different than a therapist? So we both run groups. We both do groups. How would you say a support group is helpful? And then how is it different than seeing a therapist?
Yeah, no, absolutely. I'm a big fan of support groups because I think it's one of those things that brings people together who are experiencing similar things, right? So one of the biggest benefits of support groups is just being able to meet other people that are going through similar things as you are, just like this live stream, right? And being able to talk in the chat and just relate to one another. And that's, where was I? I just lost my train of thought. But kind of like the support group aspect of it's all about kind of community building, peer support, being able to encourage one another to engage in those exposures, to fight through those triggers, right? All of the above. And it's very different than the role of a therapist, right? The role of a therapist is a lot more clinical, right? So you're helping the patient understand really like what's happening within your brain and how you're responding to certain things. And you're also adding in that coach role, right? I love to talk about how like us as therapists are coaches, right? We're able to guide you and encourage you and move you through those exposures, but it's in a little bit of a different sense, in a more clinical, like evidence-based role versus a peer support kind of motivation. You can do this together.
Yeah, I always tell people I went to a support group during my treatment, and there was something I got from it that I didn't get from my therapist, and not in a bad way. My therapist wasn't lacking anything. It was just something different. I think a lot of just like normalization, people going through it, and it was really helpful. And research backs that. For instance, the biggest research that I read was support groups for people going through cancer. They found that people were more likely to do better in chemo, be more consistent with chemo, and handle it better, and often be more consistent, which led to somebody being more successful in their chemo treatment and surviving. I wanted to throw this one up there. This is from a therapist. They said, I have a new client with severe OCD, mainly moral scrupulosity and contamination, limited insight, and a lot of superstitious beliefs. They also seem to have agoraphobia symptoms, fear of getting stuck places and not having the support they need, but related to their contamination OCD. When is this a separate diagnosis? So great question. So agoraphobia is a separate diagnosis from OCD. And typically that's where somebody feels extreme anxiety about getting stuck in a place and not being able to get certain resources or get out. Sometimes it's in a more traditional way. This could be where somebody doesn't like, I was working with someone, they didn't like to be like at the movie theater sitting in the middle seat. They didn't like to be in tight spaces. They didn't like to travel places where they weren't familiar with local hospitals. They didn't have a support system. They didn't like to be like in a car wash, even just like stuck, right? This idea that if I have a panic attack or something bad happens, there's no way for me to get where I need to go. Sometimes it actually surprisingly can be big, wide open spaces where you look around and you don't really see an exit, like being in a big field or something, right? Or just kind of being off the grid. The way that I always look back to how do you know a diagnosis is you look back to the core function. Like, why is this person doing it, right? So if it's more about contamination where they're afraid that they're going to have somebody cough on them and they can't run to get a certain medicine, or they're going to eat something that's going to get them sick, and then they're not going to be able to go to urgent care to get stomach medicine, I would say it's probably more on the contamination side, and you would know that as you treat the contamination. Do you see these agoraphobic symptoms fade? But if the person genuinely is mimicking their lifestyle, I think the extreme cases we see in movies is where somebody won't even leave their house. I worked with someone with a separate diagnosis of agoraphobia, and he mapped out where every hospital was, how many miles he can go, and because he always wanted to be a certain amount. Was OCD a factor? Partially, but it was mainly that. Just I don't want to be stuck and not having general health support systems. So I'd look at the function, and then also like what's the benefit of a separate diagnosis? Is that going to be helpful for the client? Is that going to give you different treatments and a set of tools? Or is it like, hey, you also have this, but we're going to only treat contamination? So that's how I kind of see it. I don't know if you have anything to add.
Well said.
Awesome. Well, in our final 22 seconds, I always like to kind of end it. Yeah, people are just saying good things about support groups and like letting it. I agree. Like Ash saying, it's definitely can be isolating. So it's letting you know that you're not alone. Support groups can help you feel not alone. So that's great. I think a couple of people said good stuff about support groups. All right, in our final -3 seconds, as somebody to circle back to our theme, as somebody in recovery, what would you like to say to everybody who's watching who may just like not feel confident or just don't see an end to this? What would you like to leave people with?
Yeah, and I think one of the biggest things that I've been really on lately is treatment for OCD is really, really difficult, right? It is one of the hardest things that you're probably ever going to have to do in your life. But what I'm going to say is living with OCD is even harder, right? And if we have a chance to do the hard treatment to get our lives back, let's attempt it. Right, because I think I can stand here today just so grateful for all the support that I had when I was going through my journey, and just to be able to say that I'm living a life without OCD bothering me. And that is so possible for you too, even if you don't really believe it right now, because I can tell you that I didn't believe it at first. So just keep going, keep pushing it. You got this. You have a whole community behind you, and freedom is possible.
Yeah, beautiful. All I'll add, because you said it well, so beautiful, is literally like deciding at 21, 22 to get treatment and fight in treatment and get to the other side was the single best decision I've ever made in my life. I would never go back. The only thing I'd change is having gotten into to good treatment sooner. So please recognize, do something, whether it's these live streams, a support group, a local conference, the national conference, do something to help you. So thank you so much, everybody, for being here. Although we can't be a crisis hotline and a suicide hotline, there's resources for that. What we can do is provide services here at the IOCDF. Make sure to go to iocdf.org/find-help. There's also general resources at the IOCDF. We really want you to start your recovery journey, or wherever you're on in that recovery journey, there's resources that can help. Thank you so much to my special guest, Victoria Lane. It was a pleasure. Shout out to all the folks at OCDI. Shout out to Liz McInvale. And like I said, next Wednesday, we'll be back at noon. We're going to have Dr. Sanjay Saxena, a psychiatrist who will be there to answer your medication and related questions, and I'll be there to answer the clinical ones. Thanks, Victoria, so much. Take care.
You.
Have a great Wednesday. Take care, everyone. Bye.